Good afternoon, everyone. You can hear me well?
Yes.
And you can see my slides well?
Yes.
Okay. All right. Well, it's a pleasure to be here and talk to you. I always love the diabetes educators are my favorite audience because a lot of things that I had struggled earlier in convincing people about why it matters to understand age-related barriers. Educators were the first one to identify what I was talking about. So I know that you see what I see, and we can work on it together. These are my disclosures. And so in this 20 to 25 minutes, I wanted to sort of set the stage, so to say, talk to you why older adults have unique clinical characteristics that we see and why we need to identify that. And then a lot of times goals in older adults are the issue that bothers many people. And then very briefly, some of the strategies that that we are working on that may help to improve not just diabetes, but overall management of older adults. So why should we talk about them, right? So this is the United Nations World Population showing young children and older people as percentage of global population between 1950 projected up to 2050. And as you can see, somewhere right around 2020, the line crossed where now the age under 5 is declining and age over 65 is increasing. And the trajectory is straight up. So we are going to see lots of older adults in our practices wherever we are. If you look at global prevalence of diabetes by age, you can see that in all the around the world, the prevalence increases with age, and the highest prevalence is somewhere around between 17 and 80 years of age. So we have a lot of older adults. We have higher prevalence with age. So we are going to see a lot of older adults with diabetes. So then the question is, so who do you call an older adult with diabetes? And as you know, if you are practicing in community, that one older adult is not as similar to another older adult. So if I tell you, think about an 85-year-old patient in your practice, some of you might be thinking about somebody who looks like this, and some of us might be thinking about somebody who looks like this. And you know that these two individuals needs to be cared for differently. Their goals are different. Their ability to manage the diabetes is different. And what we can and cannot do for them, or rather with them, complexity of the treatment needs to be different. But as a geriatrician, I also want to point out that this individual on the right side, even though she looks like an extremely healthy and functional individual, it's important that if she's 85, we need to take into account age as a number. And the reason for that is this concept of homeostenosis. Homeostenosis is a progressive constriction of homeostatic reserve. What I mean by that is with increasing age, there is a decline in physiological reserve. Physiological reserve is what allows us to maintain homeostasis in the presence of environmental, physiological, or emotional stress. And there is a physiological limit beyond which the body cannot restore the homeostasis, and that limit sort of declines with age. So you can imagine a stressor of certain magnitude if it happens in an earlier age, and this could be trauma, this could be pneumonia, this could be, hypoglycemia. If it happens at earlier age, then body can restore the homeostasis when it is resolved. Same amount of stressor, same magnitude of stressor, if it happens at a later age, the body is not able to go back to the homeostasis. You can imagine that pneumonia can result in acute kidney failure, and that can result in delirium, and that can result in fall and leads to poor outcome. So even the message here is that it's important to identify differences in older adults, but don't ignore the aging part of the body when you are trying to develop a safe management strategies. The next question is, where do you see or treat diabetes in older person? Now we know that there are many people, older adults, who are aging in place and they are at home fairly independently. Then there are some in the assisted living facility. You see some in the hospital. You see them in the rehab. You see them in the completely supervised facility. And why does it matter where you see this patient? Because when you think about diabetes management, where patient is matters. So people who are living in their own environment, right? They require frequent education for their diabetes, and we do that all the time. However, complexity of the medication might become a problem, especially after acute illnesses, where they go to the hospital or they go through the acute illness, and resolving that illness leads to decline in cognitive and functional impairment that may or may not be quickly resolved. And that's the time when they can make errors. They may take their medications or insulin not at the right time and get into a bigger problem. People who are residing in assisted living facility, they do not have control over the content of the meal many a times. And the other part is also that many of the assisted living facility provide assistance with administration of insulin. And some of them provide that, but in majority, they do not provide assistance with insulin or glucose monitoring. So they may provide it with the pills, but not with the injection or monitoring. So that's where they may, people who are in the hospital and then go back to the assisted living facility after acute illness, they again may not be back to their baseline as far as their functional or cognitive capacity, and they may end up in trouble if they are on complex medications. On the short-term rehab, where many people are, they may require tighter glycemic control actually, because the goal is to get them better and send them home. So maybe we should focus on tighter glycemic control, but also some self-management education that might be then helpful when they go back to their home. And then there is a long-term care facility where the consideration of care include patients having no control over either content or the timing of the meal. They are provided meal when they come in, they are given insulin when the nurse comes in. And then in addition, they are at increased risk of medication side effects. They are at increased risk of acute illnesses, anorexia, or cognitive impairment. However, if you think about it, all the activities of daily living and instrumental activities of daily living in this population is performed by nursing home staff. So if you think, broadly, if we can educate the staff properly, you can take care of 50% of this population in nursing home who have diabetes. So the problem with that is that how do you educate nursing home staff, and how do you keep on re-educating as the staff changes? So again, this is the reason why we need to know where we are taking care of the patient. And then finally, one of the major difference between younger and older adults is comorbidities. There are some comorbidities that are increased with aging as well as diabetes. And we understand macro and microvascular diseases. We know why we should look for it and how to manage that. But many at times conditions such as cognitive dysfunction, depression, physical disability, polypharmacy, so-called geriatric syndrome, that occurs with higher frequency in older adults with diabetes. and it's not intuitively looked for. And the problem with that is that many a times they are so subtle that people don't recognize them. The physicians don't recognize them. The patient's family, if they are not living with them, don't recognize them. But they do impact their ability to do self-management. And so it's important that we keep that in mind. So the broad concept of unique clinical characteristics of older adults is that they do require management of hyperglycemia as well as management of risk factors, just like we do in younger adults. However, before we develop the plan, we do need to screen for barriers, which could be clinical, as I showed you, functional or psychosocial, which interfere with their ability to do what you are asking them to do. So that brings us to the glycemic target. So when we think about glycemic target and tight glycemic control, we are weighing the benefits and risk in everybody. Benefits of prevention of long-term term complications versus risk of immediate complications of hypoglycemia, such as falls, fractures, or cognitive decline. And American Diabetes Association standard of care now has actually done a really good job of integrating this into the glycemic goals in non-pregnant adults, where people who are in good health and function and with a low risk and burdens, you try to tighten the glycemic goal as seen in A1C here, less than 6.5%. Most of the older adults or healthy older adults would fall somewhere here where you want somewhere between 7 to 7.5. Older adults with complex intermediate health, they can have glycemic goal less than 8%, and those with very complex or poor health. And we'll talk about what makes them into this intermediate or poor health. But these are the patients with glycemic goal does not really make sense. And what are the factors that define this? These are the factors that sort of favors more stringent goal versus less stringent goal. And they include duration of diabetes, hypoglycemia risk, what are the treatment risk and burden such as insulin, whether the pharmacotherapy is needed for something more than glycemic benefits such as cardiovascular, kidney, or weight and others. Whether the patient has already cardiovascular complications or how many comorbidities they have. And that's how it kind of flows in. So that's really a good broad way of looking at how we should decide on the glycemic goal. The only worry I have is that this has a lot of dependence on hemoglobin A1C. But hemoglobin A1C may not be a dependable marker of glycemia, especially in older adults, because there are, when we know that hemoglobin A1C, when we measure them, we are measuring glycation product. So the glucose that is attached to the RBC molecule. And so the lot of things that can change either RBC turnover or RBC lifespan, they can actually change the normative data of the hemoglobin A1C, and they go in different directions. So we really don't know what the hemoglobin A1C is reflecting when they have anemia, when they have recent infection, when they have erythropoietin therapy, and metabolic acidosis, or anemia of chronic disease. Since using the continuous glucose monitoring, and now we are using it very frequently, this is not really a surprise that hemoglobin A1C really does not reflect the risk of hypoglycemia or glycemic excursion. You can see CGM data on APG where the A1C here is 7.2%. So this is the time of the day from midnight to midnight. This is the glucose level, and the green line is the average glucose, right? So through the 24 hours, you see how glucose flows, and this is a standard deviation. This is the A1C 7.2, but as you can see, the pattern is completely different and a lot more hypoglycemia. This is A1C of 7.3, again, completely different pattern, and 7.4 of A1C, which is what typically we think that high A1C means that it's just high up there. And if you have just A1C in these 4 individuals, how are you going to manage them, right? They all require different adjustment in the medication. So that is one side of the scale, high blood sugar. Hypoglycemia is also not simple and may have a lot of nuances in older adults, especially on those who are on insulin or sulfonylurea. The most of the older adults, and I would say that unless proven otherwise, all older adults have hypoglycemia on awareness. What does it mean? That they don't recognize hypoglycemia. They don't get palpitations, sweating, tremors with low blood sugar. In fact, they can directly go to the brain having low blood sugar, neuroglycopenia. What that means is that they may feel confused, they may feel tired or weak, and so they don't recognize hypoglycemia. We have shown in multiple studies that cognitive dysfunction is present in about 1/3 of our patients that are coming to Joslin Clinic. So these are community living, very healthy individuals, 1/3 of them. How do you know your patient has hypoglycemia, right? First of all, patient has to recognize them. Then they have to remember that they had hypoglycemia, and then they have to remember to tell you about it. And so not having good memory can interfere with identification as well as treatment of hypoglycemia. And as I said, those brain hypoglycemia can mimic many of the conditions that older adults have, like orthostatic hypotension, or having, getting worse, their memory function getting worse, or feeling tired. All those factors then leads to patient, we don't recognize they have hypoglycemia, and this is the population that are really afraid of hypoglycemia and how they can impact their falls and so forth. That leads to patient not following the regimen properly, falls, hospital visits, and exacerbation of chronic conditions such as cognitive dysfunction or cardiovascular events. And important to remember that many a times, in endocrine world, we think that, blood sugar less than 70, it's a mild hypoglycemia, happens to everybody. However, in older adults, even mild hypoglycemia can result in poor outcomes. And you see this all the times because all the poor outcomes have multiple factors in older adults, right? So somebody who falls in the middle of the night may have a vision issue, may have osteoarthritis, walking with a cane or a walker, could have tripped on a rug there, or could be having multiple incontinence, needing to go to the bathroom frequently. And all those factors, you add even mild hypoglycemia can result in poor outcome. And there are a few factors that we can reverse. Certainly, hypoglycemia is a reversible or preventable risk factors for a very poor outcome. We actually looked at how frequent this problem is. So when CGM was a new toy, new technology, we looked at people over age of 70 years that are community living. All of them had A1C over 8%, and on 40 of them, we put a continuous glucose monitoring. And we found that 26 out of 40 had at least one episode of blood glucose going below 70 over a 3-day period. 54% of them had A1C between 8 and 9, and actually 46 of them had A1C over 9%. So we just talked about it, that A1C does not really rule out risk of hypoglycemia. And then 46% of them had even glucose going below 50, so severe hypoglycemia. And whether this kind of thing, is that a problematic? Does it matter? And Dr. Kasia Lipska has shown here that when we had a UKPDS, where we understood that high blood sugar or poor glycemic control leads to higher complication. we listen, and the national trends in US hospital admissions for hyper and hypoglycemia, for hyperglycemia, as seen in this orange line, came down very significantly. And this is again in Medicare beneficiaries, older adults. However, the US hospital admissions for hypoglycemia did not really decline that much. So now there were more older adults being admitted with low blood sugar compared to high blood sugar, which is, flip. This is a complication of the treatment of one of the chronic disease, and this is not an appropriate outcome. So what should be the goals then? Understanding how hard it is to identify high as well as low blood sugar assessment. And here is what I was telling you about the health status. So when the consensus report was developed for ADA on goals, what we looked at, was, are you still seeing my slide?
Yes.
I cannot see that. I was trying to.
Yes, we currently see a framework for goals.
Okay. So the idea was that age in number is really not very critical. We can't really do much with the age. So we developed this consensus where you identify your patient, put them into 3 different health status: healthy, complex or intermediate, or very complex or poor health. And how do you put them in different groups? It depends on 3 variables: coexisting illnesses, cognitive status, and functional status. If people have few coexisting illnesses, intact cognitive status, and intact functional status, then they are in a healthy group. The flip side or the other side of the spectrum, long-term care residents, end-stage chronic illnesses, moderate to severe cognitive impairment, or more than 2 ADL dependency, then they are in a poor health, and a lot of the rest of them kind of fall in between. Here is the rationale, and then we say tentatively it will be good to have A1C sort of separated by that. This group, although also is quite heterogeneous, so we then kind of develop this position statement, separating out the last group, where people who are in SNF, people who are in nursing home, and people who are in end-of-life care. But as you can see, none of them should have reliance on the hemoglobin A1C because it does not reflect the glycemia, because they have so many other conditions that may impact normative data of the hemoglobin A1C. So, this sort of tells you about who the patient is and where you take them. But again, it's really how you take them that matters, right? So this is sort of if you have a patient with the A1C of say less than 7%, right? How do you manage them? If they have multiple comorbid conditions, or they may or they are on medications that cause high risk of hypoglycemia, like insulin or sulfonylurea, then it would be prudent to liberalize the goal or change the strategies to make it safer. If they are less than 7, if you have a patient who is A1C of 6.9 just on the metformin and really few comorbidities, well, then they are okay to be there. However, make sure that there is a risk of hypoglycemia is assessed, and then other side effects are considered. In people with A1C between 7 to 8%, even if they, most people used to think, well, this is a good goal, right, for an older person. But if they are on medication likely to cause hypoglycemia, then I just showed you that high A1C does not protect them. So carefully assess for hypoglycemia or glycemic excursion, and then liberalize the goal. If they are not having those, then the patient is at goal. And then if they are on medication, now we do have a lot of medications with low risk of hypoglycemia, then this might be a reasonable goal if that is the best the patient and the clinicians can do. And then the hemoglobin A1C over 8%. There are some people who you will see who have multiple comorbidities, limited life expectancy, or difficulty coping with more complex regimen than what they are doing right now. In those patients, they might be that, this is the best you can do without putting them at higher risk of hypoglycemia or harm, then they are at goal. You as a clinician, as an educator can decide, just make sure that you document that. But this is not just ignoring them. This is more sort of deliberately identifying that this person will benefit from higher A1C goal. If not, then it's reasonable to get them under 8%. But then, one of the things that I was more interested was that many a times a lot of these guidelines are developed on how do you do better. If the patient is not at goal, how do you put them at goal? But then there are a lot of people you see who have done their diabetes management for decades, but now they are not able to keep up with their complex regimen. You see that they are making errors, that they are falling, that they are getting hypoglycemia. How do you manage them? And a lot of sort of times, the words such as liberalization, de-intensification, simplification, those things are sort of put in the mix, trying to improve care of this patient. But what we did was we actually developed, we had a workshop on how do you then sort of de-intensify, which many people do not like, or de-prescribe. And we said that, what, this is really a realignment. This is really not actually a one or two of this strategy. We are trying to change the patient's, the strategy to fit the patient's barriers. And we published that, and I would say that if you are interested in this is really a good paper, because we have lots of very practical algorithms, even starting from how do you convince patients that they require this realignment. And this is sort of a primer, preface where we say that if all older with diabetes do not need realignment, right? You can follow standard care guidelines and individualized management goals. When you see older patients with diabetes having difficulty with current diabetes regimen, then as step one, you seek the triggers. What are the signs or symptoms or factors that are impacting the treatment goals or strategies? Once you do that, you talk to the patient. You have to, consult with patient and care partners on why we want to do what we want to do. And then step 3 and 4 are setting or resetting the goals, and then simplifying and safer treatment regimen. And I'll give you an example. I really like this figure in the paper, which really, when you are trying to decrease the hypoglycemia and say this is sort of a continuous glucose monitoring data, or you could have same data in finger stick, but you need a 24-hour data, and then you can develop if and then sort of a context and action plan. So for example, if hypoglycemia is occurring overnight, then patient reports taking rapid acting insulin at before bedtime, then reduce or stop bedtime rapid acting insulin, or if they are not doing that, then the basal insulin dose needs to be reduced. If the patient is not taking rapid acting insulin before bedtime, then again, reduce the basal rate or basal dose. And if taking the intermediate or basal at night, then you can change it to the morning time, so the impact overnight is not as much. If the hypoglycemia is occurring after meals, then patient could be taking mealtime insulin. And then if that is so, they are overdoing it, then use the fixed reduced mealtime doses, or stop mealtime insulin that is creating those hypoglycemia post-meal. If the patient is skipping meals instead, then again reinforce the importance of matching insulin with meals. If hypoglycemia is occurring after periods of hyperglycemia, which is patient is chasing their hyperglycemia, and patient is taking the correction doses of hyperglycemia, then stop using correction doses or only use very conservative dose. For example, if you could say that only if the glucose is over 300, and then also make sure that they are not using multiple correction doses within 3 to 4 hours. And then if hypoglycemia is occurring at any time and patient is using CGM, you could integrate the CGM features so care partners now can follow the glucose level and also see if the physical activity is what is causing this intermittent hypoglycemia in these individuals. So in the sort of overall what we talked about is really to keep the eyes on the goal and help the patient age successfully, because it's not just about diabetes, right? It's about aging well. And here is an example I always love to see that this is Dr. Jocelyn, who taught us so much about diabetes at the age of 91 on the Jocelyn clinics. This is Dr. Jocelyn, age of 90 on horseback. He passed away at 92. This is what most of our older adults want, being physically active, cognitively intact and engaged. And we should try to make sure that we are not focusing on numbers so much and that we lose the sight of this broader picture. And with that, I thank you for your time and happy to take questions.
Welcome everyone, and we are excited to talk about community-based programs, especially diabetes, and our organization are very much concentrated in prevention and wellness education program. So with this, and we are talking about advancing healthy aging through community-based diabetes prevention program. That is so important. Just now, the Dr. Maha, I think, she had a very, very good information as a doctor side, clinical side. And with that, community-based organization actually work together with the people who has diabetes or pre-diabetes. Our organization will help older adults maintain, as what she said, physical activity, mental health, and social health as they grow older is very important. And we also offer our program in a local setting. So the diabetes prevention program is also helping people reduce their risk of developing type 2 diabetes. And I think most of you, I think you all know what is a type 2 diabetes. And type 1 is genetic, and type 2 is from your diet, from your food diet, and develop later in your life, Next slide, please. Yeah, so with this presentation, I really hope that by the end of this session, you will be able to understand why diabetes prevention is important for older adults, and learn that what the National Diabetes Program is. If some of you never joined or never been trained as a diabetes coach or DPP coaches, hopefully you can understand a little bit more about this program and understand how the community organization can deliver diabetes program, prevention program. And also identify the challenges and the barriers that older adults face, and what are the solutions we can help them to overcome them. Not only in the Asian community, of course, Asian community has even more challenges. But overall, when we talk about older adults, they have many challenges besides their medications, and besides how to maintain their health and grow healthy as they age. So we try to help the audience know more skills and more knowledge so that they can use it for a long term, for a sustainable future. Next, please. So when we talk about why we want to focus on diabetes preventions for older adult. And we have heard that older adult has, in general, less movement and will have higher risk of diabetes. And how we can, so that's why we want to focus on the older adults so that they can live longer and be more independent, right? And older adults also at the high risk of developing type 2 diabetes. Maybe at the younger age they never have, and when they get older, they start to develop type 2 diabetes because they have less movement, they have, many other things start to, as we grow older, many other things will come up. So in general, when we say diabetes actually can cause serious complications. We will have heart disease when you have diabetes, and you might have stroke. When you have diabetes, you might have a vision problem also, kidney disease, or nerve damage. Now, I always told our participants or at the community, I said that, when you have diabetes, for sure you will have a heart disease, a heart problem. But when you have a heart problem or high blood pressure, doesn't mean that you will have diabetes. So that's why it is very important. If you can control, a person can control their diabetes, it will help them to control other type of chronic disease or less problem of other chronic disease. And this is what we need. And many older adults already facing risk factor. Sometimes when we talk about they are overweight, they have limited physical activity, and they might have a family history, right, with the diabetes, and they might have already developed high blood pressure. Now, of course, when we talk about Asian community, that is something that at the Jocelyn, Dr. King always said, if you know Dr. King, but anyway, he's a very highly respected endocrinologist, I think. And he said that he fought for, the BMI for Asian population in general. CDC will have a guideline for BMI 25 and above, then consider you might have a prediabetes. But for Asians, because we don't generally are very heavy, but yet Asian populations has the highest or very high diabetes percentage. The reason for it is because of our diet and the food intake that we have, but not necessarily we are very heavy though. So that's why now we have CDC have put up the guideline for Asians. If your BMI is over 23, then you might have a risk of having a diabetes or prediabetes. So that is a very good step for the Asians. And yet, on the other hand, I still think that when we run this program, and we should still hope that CDC will allow Asians, because a lot of Asians, they don't even have a high BMI, and yet they have very high diabetes. So can we something like we want to, hopefully CDC will eliminate that criteria and saying that when you run this program, you have to lose 5 to 7% weight. It might work in some populations. It doesn't really work that well for Asian populations. And because we have many participants who is not very heavy and maybe even underweight, and yet they have very high diabetes, A1C, I would say, has a very high A1C. How are we going to help them to control it? How are we going to say that you should, well, we don't want to say that you should not come to the program, but with the criteria the CDC given, there is a limit for these kind of populations that who has a very skinny, not very heavy, and yet has a very high diabetes or A1C. Now, in order to prevent diabetes, it will help older adults live longer, maintain independence, and also improve quality of life and reduce healthcare costs. That's very important, right? As a community health organization, we are out there, actually, we are at the field to help support our patients or our clients who has diabetes or prediabetes. Next slide, please. So what is the National Diabetes Prevention Program, or we call it DBB, a DPP? So it is a CDC recognized program that help people to reduce their risk of type 2 diabetes. And the program actually itself is focusing on the areas of healthy eating habits, physical activity, we always stress on physical activity, and stress management. Now, why we want to do stress management? When you have diabetes, as what I said just now, when you have diabetes, you may have many other problems. Chronic disease come up as well. You might have high blood pressure, you might have kidney problem, you have vision problem, you might have food problem, many other things. It is very stressful to manage your diabetes, right? And also this program will help you to have a problem solving. We support each other, how we can resolve your problem. Now, not necessarily you will resolve your problem in 1 second, right? And that's why the DPP program or diabetes prevention program is a 1-year program. Because through the whole year, where you will be able to work on it and we help each other to resolve the problem, and your peers who are in the class together actually supporting each other and help encourage each other to be healthy, to eat healthy, to be physical activities active. So that's why it developed. I do think that 1-year program is a really, really good idea, because we have friendships, we can monitor each other, we support each other. Throughout the year, you actually will see the outcome is very successful. So our goal is to, reduce the risk of developing type 2 diabetes through realistic lifestyle changes, and also focus on long-term behavior change. So it's not a quick fix. You cannot fix it in 2 seconds, but it definitely works throughout long term, right? If you continue what we have learned throughout the year, you actually will see the effect and you see the success. Next slide, please. Probably need to be faster, I think. Okay, so our mission is to promote health equity and improve wellness in the community. And our organization also promote health equity and wellness, especially for those underserved and older adults. So who do we serve? We serve older adults, underserved population, individual at risk for chronic disease like diabetes, and also heart problem, chronic disease, blood pressure, high blood pressure. And also, so our role actually is we are actually CDC recognized DPP provider, and we have master trainer who can train organizations that who want to have their own staff to do to run the DPP program, and we are actually qualified to train the organization as for their staff to become a DPP coaches. With the support of DPH, and we really make that happen. And the other day I was talking to Jennifer, and we have been training many groups of DPP coaches so that they can run their program and in their organization, for their organization, so that the organization can eventually become a DPP provider as well. Next slide, please. Yeah, so our model actually it is a slow pace learning session. As you know that this program is a 1-year program. So it's not a quick fix. It is not one day thing. It is a 1 whole year we work together. And easy to understand material. This is a material is not developed by us, it's developed by CDC. And we encourage physical activities as what we say, and it is an evidence-based program. And we motivate and actually motivation of group support is very important. And we also have the people that who speak the language, especially for the culture. We have the Chinese coaches, we have Vietnamese coaches. Actually, my ideal case is to have eventually we'll have Cambodian coaches to help the Cambodian. We have a large group of Cambodian in the other side of the Massachusetts. And also social connections focus so that they have a peer support. That's very important, right? Older adult may be different, will have a different needs than younger participants. So the program itself has to be tailored to the older adult. It doesn't mean that we change the content of the program, because the content is actually from CDC. So we don't change the content. But when we talk to the older adult, they have a different need. We will have some of the thing that may be material that actually will be tailored to the older adult. Next page, please. So it is very important that how we can engage older adult and where can we find this older adult. We don't do it in our office because we have a lot of coaches who actually work with different organizations. We partner with senior center or community organization. That is very important, like senior housing site as well, so that the clients or the participant, they actually don't have to go out and find a taxi, find someone to drive them to certain locations. That is very challenges, and as what we say, older adult has their challenge. And we get a referral from healthcare providers. That is very important as well, so that our program can expand. Because as the doctor say, they see so many patients that with high A1C, where are they going to send? Besides taking medications, in general, they will refer them to the community-based organization who are running the programs, right? And we do a lot of outreach events, and we have also culturally sensitive communications. So we also have very flexible scheduling. Depends on the location, depends on the timing, especially at the senior housing, because we work with the local senior housing coordinators. So they work like Monday to Friday. Some are working in the morning only, one in the afternoon only, and they are the one who coordinate the program and actually call the participants to attend the class to remind them. So we have to work with them. That's a very important too. And that's actually is a very good way to engage and to find your older adult, how we can support them, rather than you have them to come on to your site where they have to find someone to drive them. I think if you can work with the senior housing, senior center, any community, as what we say, YMCA, we have YMCA, our YMCA partners in here that run their program as well. Not only at YMCA, but they also run at different locations. Yeah, next slide, please. So as what we say, how are we going to address the barriers? We know that older adult facing challenges, how they join just as what we say. One thing is the technology. Technology is really a challenge. When we say we want them to, well, why don't you go on Zoom? We have online distant learning. I give you one good example. We are running for those who has some kind of sense of how to get on Zoom, have experience of getting on Zoom or other means technology, and that's not a problem. I had one time when we have to run on Zoom, really want to encourage the adults, older adults, to get online. One time before the workshop, a few days before the workshop, I have to teach the older adult, one of the senior, to use the Zoom. I really put my time on it. It took me 3 hours. 3 hours just to teach them how to use Zoom. You think that it is so easy? It is really not, right? And that is a challenge. But I was really happy that ultimately she knew how to use it. She knew how to use it, and she really got on the Zoom, and that was a success. So that is something that we have to keep in mind, that it is not easy for them. That's why we want to do it at the local community or at the site, housing site, if senior housing site. As what I say, transportation is difficult, and caregiving responsibility. Who is taking care of them and bring them or taking care of them for their diabetes, or they have some problems, and we have to make it easy to understand. As what we said, doctors just now provided very good information about the medications and everything. Now, we are a community health educator or diabetes educator, so we don't give recommendation of what kind of medication they are taking. Sometimes you have patients coming or participants coming with a list of medications, which one should I take, and do I have any conflicts? No, we don't tell them which one they should take, because it is important that we let them know that if doctor prescribe medication to them, if they have a question or they have a problem or issues, they need to go back to their doctor. So our information has to be simple enough for them to understand. We try not to make it so complicated that they don't know they don't know what's the, what kind of information we are giving. And we have to, motivation is very important. How to motivate your participants. So what we do is, as what I say, solution is to provide technical support, reminder phone calls. That's why we work with the local community housing site, because at the site they do have a local support, local workers or manager actually working at the site, so that they will remind their participants to attend the class. And I always, every time when we go out to the community health center or housing site, senior housing site, the local support housing manager actually are very supportive. They will always welcome us to provide all these prevention education programs, and they are the one who will help you to call their seniors to come down from their housing or from their apartments or whatever to attend the class. So it is very important you work with them. And our curriculum, as what we say, is very simple, and support each other is very important. Peer support, and we support them as well. Next slide, please. So in our program, actually, you can see that as what I say, because of the support from the local site, we actually pretty much, I wouldn't want to say 100% participants achieving 5 to 7%, but it does have 95% participants achieving 5 to 7% weight loss. Now you're asking me, you say, well, I said that there are people who are underweight. Now, what are you going to do with them? We really don't want to say that they cannot attend the class, but we really tell them that they attend, but we cannot really put them as put it as a CDC data, because it is part of the requirement. CDC said you have to reach the BMI in order to attend the class, not only the BMI, but other criteria together, okay? So for those people who attend, actually 95% increase physical activities. And as I say, 90% of the retention rates, because we have the people, whether we ourselves, we do the online program or distant learning, we call ourselves, we have our outreach coordinator will call the participant to remind them that when we are going to have the program and make sure that they will attend. And most of them improve their eating habit, reduce type 2 diabetes, improve confidence in managing their diabetes. Next slide, please. Sorry, I probably. Yeah. So I give you a good example. So one of the lady actually, when she attended class, and she has a diabetes of A1C of 6.8. So 6.8 is A1C 6.8 is a diabetes already. So we told her, well, you pretty much not meet the criteria for joining our diabetes prevention program, which is for pre-diabetes only. And she insisted she want to join. I say, okay, you can come and join our program, but we really can't include you as one of the participants. And the outcome is, after 1 year, after 1 year she attended class, she dropped from 6.8 to 6.2. So we were really surprised and excited for her because she didn't want to take medication. She said that she told the doctor, why don't you give me 1 year time, and I will work on it, see whether I can drop my A1C. And I really don't want to take medication. Doctor told her that it is very dangerous. You know, she can take small dosage of it, but she insists not to take. So that's her outcome, and we were really excited for her. So it's telling us that the program actually works. Okay, and actually it will help you to change. If you change your lifestyles, and it will work for you. It will reduce your A1C or pre-diabetes. So, and also help you to help the participants overcome the challenges. So it will improve the blood sugar level, the program, and it will give you more energy, and you will have a better eating habit. It will help you also increase physical activity. Now, that's what we need to tell the participant. And also, if you do have life story to tell the participants and or demonstrate how it works, actually it will make the program even more attractive, right? Be more persuasive to the participant that they really want to work on it and they really want to join the program. Next slide, please. So, and so why community-based organization it is important? It is easy to access, as what we say. We provide social support, right? We are out there, we are at the field, we are the one that who actually facing the patients that who has diabetes or pre-diabetes. I would say pre-diabetes, especially we are talking about pre-diabetes education program. So, and it is much easier to access than hospital program. Actually, we run it according to our culture appropriate program. They can trust us because we have been in the community for so long. Also, social network, social strong support. It will actually help lower the cost for treating diabetes. Now, hospital cost is very expensive, and we are talking about lower the government billing and cost. If we can do it at the community-based organization can do it, it will be much cheaper than the patient going to the hospital and be treated when they have a high diabetes. Next slide, please. So it is very important you partner with, as a community-based organization, you partner with healthcare provider, community centers, senior organizations, insurance providers, and public health agencies. So it is important to partner with them so that you can get more referral, right? And if we can partner with the healthcare provider and community organization, it will help our program to expand, right? And improve participants' outcomes. All right, next one. Next slide, please. So our recommendation for the field, right? And so we integrate our DPP program into aging services, expand access to community program. Okay. And also we increase in referral, especially if we work together with a hospital or community health center. We do work very closely with other hospitals and community health center, and to get the referral. Again, I fully recommend that you work with a senior center, senior housing as well, because they are the one that actually will help you to expand your program, will help you to support and retain the participant as well. And when we talk about long-term funding, eventually, if you want to become a DPP provider, ultimately you can work toward becoming a MDPP provider, Medicare Diabetes Prevention Program, which you will get paid by the Medicare. That is what we are working on as well, and we had done it, and we are gonna. We had some glitches in between, but we definitely think that that is one of the way to help sustain the program. Of course, many times we said that, well, before we become an MDPP, get the funding from the Medicare, how are we going to support the program then without any funding? So we work with hospital. Hopefully we'll get some funding support from the hospital, and also apply some grants that will support these programs. That is very important.
Thank you all so much for having me today. I do want to start with giving just a little bit of context. So in my job, I work as a dietitian and diabetes educator, primarily with older adults with type 2 diabetes. However, I have personally lived with type 1 diabetes for almost 20 years now, and I'm really involved in that community. So it's both professionally and personally that I have a really strong interest in diabetes technology and advances in diabetes treatment. And I'm really invested in, educating both providers and people living with diabetes on ways that technology can make their lives easier. So in today's session, I'm going to be talking about continuous glucose monitoring for older adults, and we're going to get into some of the special considerations when you are recommending or using CGMs in this population. So my hope by the end of this session, you'll be able to list 3 potential benefits of using a CGM in older adults, and be able to describe some of the special considerations or circumstances for recommending and using CGMs in older adults. Now, this is a diabetes networking group, so I'm going to assume that most of you are familiar with CGMs, but in brief, a CGM is a small sensor that uses enzymatic activity to continuously monitor interstitial glucose levels. Those levels or readings are then sent to a smartphone app or a separate reader device for the person wearing it to see their numbers throughout the day. And the current sensors on the market have between a 10 and a 15-day sensor life. So every 2 weeks, roughly, you are removing that sensor and putting on a new one. Now, there are lots of potential benefits for using CGM devices in people with diabetes. CGMs have been shown to reduce hemoglobin A1C and help improve time and target range. It's also been shown to reduce hypoglycemia risk, which is really important for our older adult population. From the provider standpoint, the CGM reports can help guide medication adjustments or insulin adjustments. And they can also help guide kind of nutrition and lifestyle counseling or recommendations. Now, from the patient perspective, CGM can really help improve self-efficacy and empowerment. You've got all of this information at your fingertips now. What are you going to do with it? The CGM can also help create a sense of accountability. You can't ignore numbers when they're right in front of you. And this might be my biggest selling point for CGMs, is that it decreases the need for finger sticks. Now, CGMs have been around for a while. They were first approved by the FDA back in 2004, but Medicare didn't start covering CGMs until 2017. And at that time, it was with really strict guidelines for coverage. You had to be on multiple daily insulin doses a day. You had to prove that you were checking your blood sugar 4 times a day or more. So really strict requirements. But thankfully, as more and more research has come out showing the benefits of CGM, Medicare has expanded its coverage to include anyone who is taking insulin. So it could be just insulin once a day. It doesn't have to be those multiple daily injections. And also expanding coverage to include people with problematic hypoglycemia. So the standards of care in diabetes are released and updated every year by the American Diabetes Association. And the 2026 standards of care just came out earlier this year. And they recommend CGM at diabetes onset and anytime thereafter for people on insulin or non-insulin therapy that may cause hypoglycemia. And this last part of the sentence was just added to the guideline this year, and it recommends CGM for any diabetes treatment where CGM is helpful. So this is a really powerful statement because I think we can make a lot of arguments that CGMs are helpful for people with diabetes. Furthermore, in the standards of care, they have a specific section that talks about older adults. And they go on to recommend CGM for older adults with type 1 diabetes or type 2 diabetes on insulin therapy, specifically to improve glycemic outcomes, reduce hypoglycemia, and reduce treatment burden. They go on to say that a CGM may be beneficial for older adults with cognitive and or physical impairments, especially if the person with diabetes is reliant on caregivers for their diabetes management. So think about a child who is administering their parents insulin. And very importantly, the standards of care do also acknowledge that it may take older adults a little bit longer to learn and feel comfortable with new technologies. So I'm really hopeful that the Medicare guidelines will eventually catch up to use some of the language and guidelines stated in the standards of care for diabetes. Now, when we're thinking about recommending, prescribing, or using CGMs with older adults, there are a couple of special considerations that we want to be mindful of. First up, financial. So a lot of older adults are living on fixed incomes. So you want to make sure that they are meeting those requirements for Medicare or other types of insurance coverage. We want to consider glycemic goals. So for older adults, these might be liberalized. Maybe instead of a goal A1C less than 7, our goal is to have an A1C less than 8. And we are always prioritizing reducing hypoglycemia in this population. We want to consider if the older adult has any functional limitations or cognitive impairment that might impact their ability to successfully use the technology. And we also want to consider, if this person does have functional or cognitive impairments, do they have caregivers or other support systems in place who can help them to use the technology successfully? So first, thinking about glycemic goals, and as I mentioned, usually these are liberalized in older adults, but hypoglycemia is always going to be our #1 priority in this group. And a 2024 study found that approximately 22% of older adults with type 2 diabetes experience hypoglycemia or low blood sugar. And this is really important because hypoglycemia is associated with falls, hospitalizations, and cognitive decline. And our older adults are especially at risk for hypoglycemia unawareness. So this means that the person can't feel those classic symptoms of a low blood sugar, and so they don't know when it's happening. And this is particularly of concern in people who have dementia or some other type of autonomic nervous system deficit. So especially when we're looking at it from a hypoglycemia perspective, CGM can be really helpful because it's going to give off alarms or alerts if the blood sugar drops too low. If there's a caregiver involved, those alerts can go to the caregiver. Or as providers, we can download these reports and see exactly when and how often low blood sugars are happening for this individual. So I do want to give you an example of this here. So this is an actual CGM report for a 76-year-old who is living alone in the community. And this person is on insulin once a day and then some other diabetes medicines. And what I want to point out here is that if we were just using traditional monitoring, such as checking an A1C, this person's A1C would actually come back at 7.1%. And we'd probably say, great, keep up the good work, keep doing what you're doing. Similarly, if we were just asking them to monitor fasting blood glucose levels, those numbers would probably come back about 100 to 120. And again, we'd say, great, like you're doing a great job. We're going to keep up with the same treatment plan. But now, because we have the CGM reports, we're getting all of the puzzle pieces. And we can actually see that this individual is running low. Their blood sugar is running low about 12% of the time, specifically overnight. So now that we have that information, we know what's actually going on throughout the whole day. We can either adjust medications to address the hypoglycemia, or we can adjust the treatment plan, maybe some nutrition counseling about ways to avoid this. Because again, within the older adults, we really want to prioritize decreasing hypoglycemia. Next, we want to consider if there are any functional limitations. As people age, they tend to develop different types of limitations, particularly for people who have maybe had diabetes for a long time. They might suffer from neuropathy, and this can make finger sticks painful or maybe impair fine motor skills, that person's ability to really either check finger sticks or to self-apply the CGM sensor. Also, anyone who has maybe suffered from a stroke and has hemiplegia, so they only have functional use of one side of their body. And I had a patient a few years back, and she had type 2 diabetes. She had suffered a stroke. She was taking insulin. And at that point in time, she was self-monitoring finger sticks. But when she would bring in her glucometer, the numbers were always at random times of day, and they really weren't useful for evaluating, is this treatment plan working for you? So I asked her, I was like, can you show me how you're checking your finger sticks? And she pulled out her meter, and again, only using that one functional arm, it was really difficult for her to do finger sticks. And it took a long time. It took about 10 minutes for her to check one finger stick. So it's really not realistic that we were asking her to check finger sticks multiple times a day once we understood, how much of a cumbersome process this was for her. So she ended up getting CGM. She was a good candidate for the CGM. And this allowed her to see her blood sugar numbers throughout the day. And it relieved her of that burden of having to do finger sticks. When we are thinking about functional limitations, we also want to consider if the individual has any visual impairment that might impair their ability to read the numbers on the screen or to apply the CGM sensor itself. And we also want to be mindful of any hearing impairment that could impact someone's ability to hear the high or low glucose alarms and participate in education about it. So thinking about just the visual impairment piece. So I have a gentleman that I work with who has type 2 diabetes, is on insulin, has had it for many years, and he's also legally blind. So he has a visiting nurse who comes every day and administers his insulin, but he also has a CGM. And while he does have a lot of trouble reading the numbers on the CGM screen, he pointed out to me that, he can see colors. And CGM results, the CGM screens are color coded. So if the blood sugar is low, it's going to be a red screen. If it's in range, it's going to be white or gray. Or if the glucose level is running high, the screen is going to be yellow. So throughout the day, he can still look at that screen and look at the color and understand generally where his glucose levels are running. So I thought that was a really cool adaptive strategy for someone who was struggling with visual impairment. Next up, we can talk about alarm settings. So these are highly customizable across the board on the different CGM brands. And if you are working with someone who has hearing impairment, you can adjust the volume of the alarm settings. Or if someone has a really significant hearing impairment, you can actually set the alarms to vibrate, and that's how the alert will go off. You can also customize the settings by adjusting high and low glucose alarm thresholds. So this can be really useful, especially for older adults who might have liberalized glucose targets. Let's say we've got someone whose goal is to have an A1C less than 8%. Now, an A1C of 8% is about 183 milligrams per deciliter. So if we use the factory settings on the CGM, that alarm is going to be going off every time the person's glucose goes above 180. So potentially, half of the time this alarm is going off and it's going to drive the person crazy. So if we have, again, someone who is more liberalized in their targets, you can adjust that high glucose alarm. So maybe it doesn't go off until the glucose levels hit 240 or 250, just to make it a little bit more user-friendly. Similarly, you can adjust the low glucose alarm setting. And I've done this for several of the patients that I work with, again, because we want to prevent hypoglycemia. I will actually set their low glucose alarm to go off if the glucose level drops below 100, because I don't want that person to wait until their blood sugar is low for them to hear an alarm and start making an attempt to treat the glucose. So by setting the low glucose threshold to go off a little bit higher, it gives them time to get up from the chair, to get to the kitchen, to pour a glass of juice, or however they're managing it before the glucose is actually low by the time they find out. So again, alarm settings can be highly customizable, and I'd recommend doing that on an individualized basis. Now, CGM and cognitive impairment or dementia, I've cited a couple of studies here. One that in particular found CGMs helpful for caregivers who were managing diabetes for older adults with dementia. And a second one, so this was done in 2025, and it was looking at older adults with Alzheimer's disease and diabetes. And they compared CGMs to self-monitoring of blood glucose, so just traditional blood glucose monitoring. And they found that the CGM users had decreased rates of general hospitalizations, decreased rates of hospitalizations related to the hypoglycemia, and overall mortality than those who were doing finger sticks. So this is a lot of kind of the pro side of things. Anecdotally in practice, I've seen it be a really mixed bag. So I've had some older adults with dementia and their caregivers have found CGM to be so helpful because they're not stressing about, what are the glucose levels running right now, or they're not fighting with the person to monitor finger sticks. And it gives the caregivers themselves a lot of peace of mind. I've also had cases where, the older adult with more advanced dementia or Alzheimer's disease has the CGM put on their arm, and then 10 minutes later, they're like, what the heck is this on my arm? I don't want this. And then they take it off and throw it in the trash. So again, we want to be really individualized here with our recommendations and our treatment plans. And last, but maybe one of the most important pieces here is training on CGM use. So it's important that we recognize older adults may require more time for training and education. And that's not across the board. Again, we want to treat every case as an individual. However, a study completed in 2024 found that on average, older adults needed an extra 41 minutes on training and support for how to use their CGM within that first month of use. So kind of thinking about that, if you are recommending CGM for older adults, just considering, we're going to book an appointment today, we're going to book a follow-up appointment in a week, maybe a phone check-in, the week after, just to make sure that older adult is really feeling comfortable and confident in how to use the technology. And then, of course, if that individual is reliant on caregivers for their diabetes management, we want to include those caregivers or family members in the education session so that everybody's on the same page. So in summary, I think CGMs are really, really wonderful tools. They can make life with diabetes a lot easier. But we do want to kind of weigh the pros and cons of CGM use on an individualized basis. We want to consider if there are any cognitive or functional limitations that the person's working with, and either come up with some adaptive strategies to help them use the tools successfully. We want to include caregivers, family members, other support systems in education as needed, and understand that it may require a little bit extra training for that individual to be comfortable and confident using a CGM. And then I did not mention this earlier, but we want to periodically reassess if the CGM is still beneficial and in line with the individual's goals of care. Particularly if someone is maybe nearing end of life, or their diabetes is no longer the #1 priority. Is this tool still helpful for them, or is it causing a burden? So here are my references. Thank you so much for having me.